Much. Our next speaker is Colonel Vijay Kumar Sharma. Colonel Vijay Kumar Sharma is going to speak on cystitome or forceps in capsulorhexis, which is better. Colonel Vijay Kumar Sharma is presently professor and head of the department at at AIOC2024, Pune. He's a prolific cornea, refractive, and cataract surgeon. He is alumnus of RP Center, AIMS, and has many firsts to his credit. Vijay, without wasting much time, because we've got less time, so I'll ask you to give your presentation.
Thank you, sir. Thank you for the introduction. So I'll be speaking about continuous curvilinear capsulorhexis. So as all of you know that if you get a good CCC, the outcome of your phacoemulsification surgery will be very good. So there are many individuals, rather most of people, they prefer cystitome over forceps. So which one is better in which scenario? So I'll be discussing about that. So as you know that continuous curvilinear capsulorhexis, normally the size that we want to achieve during surgery is around 5 to 5.5 millimeter. That should be roughly around 0.25 to 0.5 millimeters smaller than the optic size, so that the IOL centration is very good. Now what is the basic difference between a cystitome and the forceps? In the cystitome, what you are doing is you are making a flap, you are reflecting it over to the remaining capsule, and in the same plane you are doing the directed rhexis by dragging it over the remaining capsule. Whereas in forceps assisted capsulorhexis, what you try to do is you lift the flap away from the surface of the anterior surface of the crystalline lens. So by then directing that force, by lifting it over to the anterior chamber, that is how you try to achieve the continuous curvilinear capsulorhexis. Now in both the techniques, as far as the normal cases are concerned, routine cases are concerned, both techniques do equally well, whether you use a cystitome or you use a forceps. The difference start coming in the outcome as soon as you get the hypermature cataracts or complicated cataracts. So that is the time when you have to be very careful, and how you should go about, we'll see some of the cases. And also usually what is said that, so these were the videos which were done using the cystitome. I'll just show you one video where normally we use the, this is a Utrata forceps which is used. So with the tip of the Utrata, you just make an initial incision in the capsule, and you can just lift it up, and you can make the size of the capsulorhexis that you want, and that you are convenient with. So now this is, let's discuss some other cases. Now this is a case of hypermature cataract. Now in this, in the center, you are seeing there is a very thick calcified anterior capsule. So with the needle, when we try, with the cystitome when we try, we are not able to make entry into that. So there are two techniques described for this. One is either you peel off this calcified capsule, or you make a incision on the side of this if it is it can come in within the capsulorhexis margin, and then you can use a Utrata forceps to do a good capsulorhexis in this. Be sure that during the when you are doing a CCC, if you are getting some extensions, then you should add visco and then complete the rhexis. Once you complete it, then the further surgery becomes much easier in these cases. So I'll go to another next video. Now many a times it happens that in hypermature cataract, the intralenticular pressure is very high, your cortex is highly liquefied, and in these cases it is said that if you do a rhexis using a cystitome, then you get an Argentinian flag sign much more higher as compared to the rhexis. I'm showing this video to show that you can get an Argentinian flag sign including even with the Utrata forceps. So that is why placement has to be. Now just see here, I'm going to the edge, and as soon as I try to pull, the capsule extended. So again, what comes to the rescue is your forceps, how you can manage the forceps intraoperatively. So what you do is, meanwhile when we were trying to manage on one side, the intralenticular pressure was very high, and then the Argentinian flag sign happened on the other side also. There were two sides. So then we just use a MVR Caesar, and then extended that and then converted that into a round rhexis on that side, and then we completed the phacoemulsification in this case. You have to be very careful, especially if you have got radial tears like this. So in those cases, you should be very careful. Now this direct chop is quite safe. Once you do the direct chop, you can remove the entire nucleus. You have to be very careful. Don't let the AC collapse. So once you have completed the phacoemulsification, don't withdraw your phacoprobe immediately. What you do is from the side port you inject the viscoelastic so that your capsule doesn't come forward because you have a radial tear there, and then you come out, and then you can complete the phacoemulsification even if you have got radial tears in situations like this. So let's go ahead to some other cases. So this case again a case of complicated cataract. You have got a very thick fibrous membrane here, and also you have got vascularization over to the anterior surface of the capsule from the iris. Now again in such scenarios you have to innovate in between. So initially the superficial membrane we removed using a MVR scissor and forceps. So after this membrane is removed, we created a space so that we can, now you just see the how thick is the membrane. You can hardly pull it with a forceps also. So we created 4 places where we can insert the Maligan ring. Once these places were 4 spaces were created, we injected the Maligan ring, and the scrolls were tucked in under the iris, and we got at least a relatively decent dilatation at this point of time. Now the second challenge is to manage the thick fibrous membrane that we have. Now in such cases you can use a MVR. With MVR, these thick membranes you can gently lift and also peel off. So you just lift it, and wherever it is attached to the remaining capsule, you just cut that place, and once now you can see the how thick is the membrane. So it's actually a fibrous membrane with the capsule, with the cortical matter. So all those have thickened into a thick membrane, and this is the site where the interlenticular vascularization was coming. So that also we removed, and once this was completed, you keep on injecting visco so that you get a good formed anterior chamber during the entire surgery. Now this is the membrane with capsule with some cortex, and when it is removed, you can complete your phacoemulsification surgery ahead of this. And also we inserted the put the intraocular lens also without any complication in this. Okay, let's see, this is my last video. Now in this what you are seeing is a coloboma, 30-year-old patient who had a coloboma, who had a very, it was a total cataract, and also the membrane was very, very thick. Again the same thing, the capsule, the cortex, everything was a one thick membrane. So we tried with the initially with the cystitome. Now here we are trying with the forceps. We are not able to gain any entry into the capsule from where we can start a capsulorhexis. So what we did is, see, now we are using a scissor also, but we are not able to get the scissor also into the this membrane. So again we use a MVR blade, made an entry, and made an entry point into this thick membrane. Once we made this entry point, then we could insert the blades of your MVR scissor. Now we got at least one plane where we can do a capsulorhexis in such a thick fibrous membrane. And now you can see after that, now we can hold it with the forceps. We can complete the remaining capsulorhexis in this. And again, you have to be very ambidextrous using the MVR scissor, MVR forceps. You have to be very careful. And now once this membrane was removed, this patient also had a traction return detachment that was planned for a stage 2 surgery. So coloboma, because of coloboma, we could not put a Maligan ring in this, so we use the iris hooks in this, because on one side iris is not present. So in such cases, with Maligan ring, what happens is intraoperatively with the fluidics, the Maligan ring just gets removed out of the iris. So it's better to use in colobomas the iris hooks compared to your rings. So now once this was completed, then we removed the total cataract. The total cataract was removed, and after the cataract was removed, we could insert a foldable intraocular lens into this, and these are the last pieces. And so after putting the intraocular lens, now this remaining membrane we had kept very deliberately, because we didn't want the extension of our rhexis margin. No, hardly there is any rhexis, but these membrane were very tough. So whatever manipulation you do, nothing will extend. So after you have put the intraocular lens, the remaining cortex and the capsular membrane that was present, that was also removed. And now the patient is planned for vitreoretinal surgery for tractional detachment after this. So with this, the take-home message, what I would suggest is you need to be proficient in both the techniques. In a routine cases, both cystitome and forceps, they do equally well. But forceps, they have an edge over cystitome, like in the cases I showed in pediatric cataracts, in hypermature cataracts, and in complicated cataracts. Thank you very much.
Thank you, Vijay. It was a wonderful presentation, Vijay. Seeing your videos, it was really, you get really awestruck how beautifully you've managed those complicated situations. I have to add 2 more points in this. In case of, if you're using a forceps, try using 25 gauge forceps, in the sense those ILM forceps, serrated forceps, because you don't have to increase the wound size. So if you're using a forceps, a bigger forceps, then you have to increase the wound size to 2.2 or 2.8. Then because the AC becomes flat in those cases, and then the chances of running of those rhexis is quite high. Secondly, in case of a hypermature cataract, we have a very wide and hypermature cataract when you suspect that the intralenticular pressure and the intravitreal pressure is also high in those cases. You just do a plain simple, put a non-walled trocar 4 millimeters from the limbus in infratemporal quadrant. Just wait for some amount of vitreous to come out. Don't be scared. This may look initially scary, but it's a very, very useful tip. You all try it, and it's going to be a very successful tip, that you put a non-walled trocar 3.5 to 4 millimeters from the limbus in infratemporal quadrant. Just wait for the vitreous to come out, and the eyes become immediately soft. The chances of rhexis going out becomes very less. These are my 2 points to add on these cases. But otherwise, Vijay has shown that how beautiful surgeries, this complicated surgeries can be.